Hello, everyone. Hello. Thank you for joining us in this webinar. Today we'll be talking about DoxyPEP, strengthening the STI prevention toolbox with equity at its core. And this webinar is part of the Gay Men of Color Fellowship. It's a program developed by NMAC to develop the capacities of a cohort of gay men of color throughout the US and Puerto Rico so that they can lead the movement within their own context to address disparities affecting these populations around HIV and also STIs. And for today's conversation, I'm super excited to be joined by a panel of experts that I will introduce. First, we're going to start this conversation with Taimur. He's the Associate Medical Research Director at the Fenway Institute at Fenway Health in Boston. He received his Master of Public Health and Doctorate of Medicine from Tulane University in New Orleans, and he's an HIV STI expert. He has served as sub-PI, PI, you name it. And he's also been working to address disparities for communities of color. And we also have Jen Hecht from BHOC. She's the co-founder and director of Building Healthy Online Communities, that's BHOC. Jen has 20 years of experience in the field of sexual health and substance abuse, having worked with Sharing's Access, HIV prevention outreach, and community health clinics. Her work also includes development, evaluation, and community-based research. And also regarding to DoxyPEP, they have done an amazing work to make sure that the community has the right information. And we are going to put on the chat some resources that BHOC has developed. And also, we are joined by Raul Marca. Raul is part of the Gay Men of Color Fellowship, and he's also a senior program manager for the Sexual Behavioral Health Program at the Wyckoff Heights Medical Center in Brooklyn. He does field work with vulnerable populations, including immigrants and the LGBTQI+ community. And he has also participated in the Let's Stop HIV Together campaign as a community ambassador. And also for those of you that didn't know, NMAC is also a partner with the CDC to support them in expanding the Let's Stop HIV Together campaign. We are going to put links on the chat where you can access the website in English and in Spanish, but you can find their information about how to address stigma, prevention, treatment, and also they have a really cool tool where you can find services near you based on your zip code. And in this conversation, what we really want to make sure is that we address the doubts that the community has around DoxyPEP, make sure that they have the right information, but also to make sure that we have the conversation about how we can ensure equity as this technology is implemented around our communities. So now I will pass it over to Taimur. Take it away.
Am I a presenter? Almost. Can you hear me okay, Damian? Perfect. And do you see the right screen? Yes? Okay. I'm assuming you can hear me and you see the right screen now. So I'm gonna get started. Hi, my name is Taimur. I am the Associate Medical Research Director at the Fenway Institute in Boston, Massachusetts. I'm also a provider here, which means I take care of some patients in the clinic. I use he, series pronouns, and I had given an iteration of this presentation back at the last NMAC conference in September. I've updated it a little bit since that time, but hopefully a lot of the information should be, if you're at that, should be a refresher with some additional updates. So let's get started. There's a lot to cover. Let's see. There we go. So the agenda for this talk is going to be the following. We're going to be going over STI trends, and then we'll be doing DoxyPEP, like what the studies have shown us that has brought us to the point where we're at right now. Following that, I'll give some special considerations and gaps in data. So where are we with the data? What's left to kind of investigate before I think some people may feel more comfortable once we have those gaps filled. And then we've got some special considerations. If you decide to do this at your clinic or center, these are some things to consider to, when when creating protocols or workflows for your own sites. And then lastly, we'll talk about the national guidance that is currently under review at this moment. So STI trends. So we know STIs are a problem. The WHO stated in 2021 that more than about 374 million new curable STIs are diagnosed every year. And specifically, when I talk about STIs, I'm talking about bacterial STIs. So I'm talking about gonorrhea, syphilis, chlamydia. There are, of course, other ones like mycoplasma, canker, all these other ones that can occur. But the three main ones we're thinking about are gonorrhea, syphilis, and chlamydia. We know for gonorrhea that where there's concerns about antibiotic resistance, which I'll hit on later in the talk. We also know that if gonorrhea goes untreated for extended periods of time, it can cause infertility. And there's also known increased risk of acquiring HIV in these populations, given the amount of inflammation and irritation at sites where HIV can enter the mucosa. For syphilis, we know that there are very concerning end-stage damage, end-stage organ damage that can occur if it goes untreated or undiagnosed. Specifically, you can have heart failure, cardiovascular issues, you can have neurologic issues with neurosyphilis, which can cause meningitis and issues around memory and mobility. And then if it goes undiagnosed and untreated in pregnant patients, it can cause congenital syphilis, which I'll also talk about. And with chlamydia, we know that can also cause similar issues that you would see with gonorrhea, so infertility and concerns around ectopic pregnancy. Because it's worth mentioning now, the mainstay first-line treatment for chlamydia is doxycycline. For syphilis, it is one of the two first regimens. It is either doxycycline or penicillin, but there's a penicillin shortage right now, so a lot of patients are receiving doxycycline for syphilis. Additionally, our CDC released data in 2021 stating that there have been increases in almost 30% of cases of gonorrhea, huge increases in the cases of syphilis, and even more recently, this was released yesterday. So yesterday, the CDC released data to suggest that there has been a 10-fold increase in cases of congenital syphilis. And most of these, 90% of them, could have been prevented if there was timely testing and treatment during pregnancy. There is a chart available at the CDC site. I encourage everyone to look at it. The website is listed here. And if you go to the CDC site and type in congenital syphilis, there's actually a map by county showing which areas are of higher concern, and you can find that available to you at that site. So what is doxycycline? So doxycycline is an antibiotic, as we all know. What is it used for? And I added a couple slides here because I heard a lot of buzz from the audience at the last session I presented this at, but doxycycline is used for a lot of stuff. For bacterial infections, we use it for skin and soft tissue infections. We use it for pneumonias, different types of atypical pneumonias. It's used for Lyme disease. It's used for the plague, tularemia. It's used for anthrax, malaria prophylaxis. And then more commonly, it is also used for acne and rosacea. And then we know that doxycycline also has anti-inflammatory properties. So sometimes it is even given as an anti-inflammatory agent when compounded with other things going on in the body for like things like arthritis and bullous pemphigoid. That's a little less common, but it does have that ability. So it's used for a lot of stuff, and it's not like it's new either. I included this chart at one of the sessions to show all the different antibiotics. And this is not meant to be information I expect you all to obtain, but what I'm doing here is showing you that from the point of discovery till now, doxycycline is one of the older antibiotics in the class of tetracyclines. It's been around for a long time. So what we know is that this drug is safe, it's well tolerated, it's inexpensive, and we know that it's a really active agent for syphilis and chlamydia. And there have been no documented clinical cases of resistance to those organisms, chlamydia and syphilis. Now with gonorrhea, we don't use it as first-line treatment. What we use for first-line treatment for gonorrhea is ceftriaxone, or in a class of drugs called cephalosporins. It is not even used as second or third line, honestly. We use fluoroquinolones and other fourth, fifth generation cephalosporins if the need occurs. So tetracyclines and doxycycline aren't generally used. And when we've looked at cultures of gonorrhea, we've noticed that there's about 20% resistance in the population for gonorrhea with tetracycline, specifically doxycycline. So how do we get to this point? How do we go from a drug that was around in the 1940s that's been used for a bunch of stuff to now talking about DoxyPEP, which is using doxycycline as post-exposure prophylaxis after condomless sex to prevent bacterial STIs? How do we get here? So in 2015, there was a study called IPERGAY. This was based out of France, and it was looking at the on-demand PrEP regimen. Within this study, they had included a branch that was looking at patients receiving doxycycline after having condomless sex, oral, anal, and they found that there was a pretty impressive decrease in the number of cases of chlamydia and syphilis. At that point, they did not have good data on gonorrhea. And then in 2022, last year, at the AIDS conference, Lutmeyer et al., based out of California and Seattle, did a study called DoxyPEP, and they found data that was later published in the New England Journal of Medicine, stating that among MSM and transgender women who had recently had a bacterial STI, if they received doxycycline as PEP, post-exposure prophylaxis, they found a 60% decrease across all 3 STIs. So that is across gonorrhea, chlamydia, and syphilis. Over here, you'll see people living with HIV. Over here, you're going to see a PrEP cohort. These are the 2 cohorts they looked at. Standard of care is here, standard of care is here, and this was the decrease across all of them. There was significant decrease in all 3, right there. This is the basis for this indication. They found that, to conclude, that it was safe, acceptable, and that there was high adherence. The patients were really interested in this. Patients really wanted it. They did qualitative studies asking these questions, and there was pretty much consensus for the most part. So where are we now with this in terms of new studies? So the group that did the IPERGAY study, Melina and her lab, had looked at a new regimen looking at doxycycline as PEP along with the gonorrhea vaccine. So both of them together, and that was called DoxyVac. And that is a study that's still currently ongoing. So I don't have data to suggest we know what's going on with that quite yet. DPEP was a study done out of, actually, I think I have a slide for it. Yeah, out of Kenya, looking at cisgendered women receiving DoxyPEP with their HIV PrEP. Unfortunately, the data for some reason showed that there was no difference in cisgendered women and their first STI occurrence. However, it was believed that this was likely due to adherence. So when they actually looked at self-reporting adherence, they said, oh, wow, a lot of them reported good adherence to this regimen. However, there was supplemental hair testing to look at concentrations of doxycycline that was in the body, and it found that 44% had never seen doxycycline because it lingers in the body for a while. So there was a question about adherence. So then it got a lot of researchers kind of scratching their head and saying, well, why is this? Is it something anatomical? Does it have to do with tissue penetration, pharmacokinetics? Like, what is it? And so this made us think that there was a discrepancy in what was being reported and what was being taken in terms of what was showing up in clinically. There was an additional study done by Holland, and this was presented at CROI. And all this is looking at, and this is just basic science looking to see where concentration of the doxycycline occur in cisgender women. They found that it was pretty consistently across multiple sites, vaginal secretions, rectal, and they even did throat sampling. But given this data, we would expect that if doxycycline is available in the tissue, that it would be effective. So the studies are still out. We're still looking at cisgender women to see whether or not this has clinical significance. Okay, that is a gap in data. Now, other gaps in data, and the one that I hear the most about is from providers and patients, but more providers than patients. And that is about antibiotic resistance. You're telling me I have to take an antibiotic to prevent an infection. You know, we've spent the last decade and a good part of the decade talking about antibiotic stewardship and making sure we don't give unnecessary antibiotics to a lot of people. The good news is, as I mentioned in an earlier slide, there are lots of antibiotics out there. And this is a rather old one that we already know is pretty effective for a few things, first-line regimen for those things. And there's no real major concern for gonorrhea at this point because we know it's resistant and we don't usually use it for gonorrhea. In the studies we have so far, there is no concern for increasing antibiotic resistance with gonorrhea. So right now, with the data we have, which is limited, we don't see increasing drive to worsen antibiotic resistance in gonorrhea. And theoretically, this is why I wrote this in italics, is theoretically, if we reduce all cases of gonorrhea by 60%, right, then our need to expose or treat patients with ceftriaxone decreases. We can expect by models that it would decrease by 50% the need to use these other antibiotics. And if we're not using those other antibiotics, then there's likely to be decrease in resistance long-term, right? Less antibiotics used, less resistance. Less cases, less antibiotic use. So we're hopeful. Granted, we are still looking at this. So whenever you get, and our Department of Health in Massachusetts requires or strongly encourages that we do cultures of any positive gonorrhea infections, so we can look to see what is the resistance pattern that's kind of creeping up in our community. Okay, so we've talked about cisgender women, we've talked about concern for antibiotic resistance. What else? What else are we worried about? What is the gap? And I mentioned, what about chlamydia and syphilis? I've been saying that there's been no clinical cases, and there haven't. There has not been a case where someone's been diagnosed with chlamydia or syphilis and an antibiotic has not treated that patient's symptoms. But that's tricky because chlamydia and syphilis are also really hard to test for. If anyone here is a provider and knows the way we test for syphilis, it is not straightforward. There's no culture. There's no syphilis culture that we do. And chlamydia lives within cells, so it's hard to kind of get that information. Granted, we don't have the best tests for these things, but they're sufficient to help us treat. So what we know is symptoms equal positive test equals good treatment. What we don't know is whether or not our treatment right now is causing some hidden resistance pattern that we haven't seen yet. It hasn't occurred yet, but that doesn't mean it can't occur. So that is something that we're just taking a mental note of. And then lastly, people have concerns around what happens to the bacteria that lives on our body. Bacteria is not good or bad inherently. Bacteria can act poorly, and that is what we're talking about here. So when we get antibiotics in our system, the staphylococcus that lives on our skin can build a resistance to it, and that's what we get, methicillin-resistant staph, so MRSA. And even though doxycycline is not a methicillin-related drug, it is something that can push for additional resistance. So far, data has suggested that that is a non-issue. There has been no increased rates of MRSA on people's bodies and in their bodies that is concerning in people that receive doxycycline so far. The other question is gut flora. What is happening to my gut biome? People are taking probiotics, et cetera, et cetera. Doxycycline doesn't typically affect a lot of gram-negative organisms. So what does that mean? Gram-negative organisms are the ones that are predominantly in your gut, those and anaerobes, bacteria that don't require oxygen. And so because doxycycline doesn't really affect them, we theorize that it would be a non-issue. When I presented this slide previously, I was able to say that with some reluctance, theoretically we shouldn't have issues. But if you want to Google doxycycline November 1st, C. diff or Clostridium difficile, there was data actually published in the Journal of Infection stating that doxycycline use for pneumonia has been associated with a marked decrease in C. diff infections of the gut, stating that when you give antibiotics for pneumonia that's community acquired, people can get C. diff infections of their gut. But doxycycline was shown to be protective. So another added theoretical benefit to receiving DoxyPEP. So these are our big concerns. These are the things we don't know enough about, right? We don't know about cisgendered women or assigned female at birth patients. We don't know about gonorrhea antibiotic resistance, although right now we know there's no increased worsening of it. We don't know if syphilis and chlamydia are quietly gaining resistance, although it's very unlikely because we've had no cases of that. And then changes in gut flora, something that is theoretical that could happen down the line compared to something that's a real risk right now, which is congenital syphilis, increasing cases of gonorrhea and chlamydia. So that's the payoff we have to kind of look at, is how do we balance a real risk, something that is happening now, uptrending, with something that theoretically could happen in the future. And that's kind of what medicine is, right? Pros and cons. So what do we do at Fenway? At Fenway, we are a federally qualified healthcare setting based in Boston. We have 2 sites, one located in the Fenway area, which is where we got our name, as well as one in the South End, which was predominantly an LGBTQIA concentrated area of the city. We provide care to approximately 35,000 patients, and 2,200 of them are people living with HIV. And as of the last data search we did, we noticed that we had about 3,500 active PrEP patients in our system. At the Fenway Institute, we do some studies and advocacy work. And what we received at the beginning of last year was money from the CDC through NACCHO to see how we would implement the use of DoxyPEP data in our clinic. And so we used, we had a Fulbright scholar, Michael Traeger, come in and look at our patient population, create this model. And this model helped us to differentiate who we should target to receive DoxyPEP. And all this showed us, and I'm going to summarize it for you, is that the number needed to treat was most effective if we targeted anyone that had any STI in the last year. So using that information, we created indications within our system to say, hey, if you received a diagnosis of a bacterial STI in the last 12 months, you should consider taking DoxyPEP, because what we realize is you're likely to have another bacterial STI in the next year, and this may be beneficial for you. We have included that as part of our guidance. And then we also said, if you've had multiple, more than 2 sexual partners in the last year who without condom use, then you would also be eligible. And lastly, I included a section here that says shared decision-making. At Fenway, we try to encourage an informed consent model. And all that means is we are not the parents to these patients. Our job as providers is to educate our patients, to make sure things are safe, that they are informed of the safety concerns, and that the patient makes a decision for themselves. And so this box tends to get checked off for those assigned female at birth patients. So if someone's coming in and they are a transactional sex worker and they have been getting recurrent STIs and they really want to try this, they have no interest in getting pregnant, etc. There's no other contraindication to them receiving this, then I say, okay, shared decision making, we don't have the data for it. Theoretically, it should work. I'm happy to prescribe this for you. And that's how we proceed with that. The coding we use, as you may start thinking about how you want to implement this at your site, the coding we use is Z20.2, which is exposure to STI. We've created a specific order for the doxycycline script. This allows us to track who's been using DoxyPEP and who hasn't, because it's a very specific script. We give about 25 uses of 1 refill, which should get people to their 3-month mark if they're a PrEP patient. We've created smart phrases for our providers to easily document what is going on in the visits, so that way they don't have to learn both about counseling a patient about this and how to write it. So we've provided tools to help them chart this, as well as a plan section here. I've also created this patient instruction smart phrase, which gives any patient who may be interested in starting or is starting taking doxycycline as post-exposure prophylaxis. It says very clearly this is not 100% protective, but data suggests a 60% decrease. I have created this slightly confusing, but some patients find it helpful way to remember, which is 3-2-1, which is within the first 3 days, preferably first 24 hours, or first 72 hours, take 2 tabs, because doxycycline comes in 100 milligram tabs or capsules, once for each sexual encounter, but with a limit of only taking it once in a day. It is safe to take doxycycline every day, but not to exceed the 200 milligram limit. We also encourage patients to drink water with it or have it with the meal if their stomach is sensitive. We encourage patients to sit upright after taking the medication so as not to lie down and get piloesophagitis, and that we're still learning stuff about it, including what it does to the skin flora, to the good bacteria of the gut. Data we're still looking at is resistance patterns. And if people have symptoms of an STI, they should come in, right? Because you can still have breakthrough infections, but they don't need to come in if they're asymptomatic. And we do advise against people who are breastfeeding or pregnant. So this is the information we provide. We now have over 1,000 patients at Fenway that are currently prescribed DoxyPEP, and that's just showing the upward trend. We had to do 3 trainings for staff. We found providers to be a little bit more reluctant on taking this up. There were a few providers that were really good about it, but not until providers had seen the information multiple times, so they feel comfortable kind of advocating for this in their patients. And so I've given you kind of like the model we have at Fenway, and here's some additional information if you want to feel empowered on taking this back to your communities. Number 1, there are very few contraindications to doxycycline. Number 1, pregnancy, breastfeeding. I mentioned that already. Intolerance to the medication. You know, some people are really sensitive to the GI symptoms that come with doxycycline and tetracycline. So you can counsel people with mild to moderate symptoms of nausea, vomiting, but if someone's got really severe esophageal or GI issues, then I would say, you know, maybe this isn't for you. Hypersensitivity to any medication. It is really rare for doxycycline, but it can happen theoretically. And severe liver cirrhosis or kidney disease, dialysis. That's the way the medication is metabolized, and we just want to make sure that we're not causing toxic levels to occur. Again, very rare. What are some drug-to-drug interactions to be aware of? Since doxycycline is an oral medication, we want to worry about antacids and iron supplements that can kind of bind to the antibiotic and prevent it from like fully dissolving in the gut. Blood thinners have been shown to interact. So we say if you're taking warfarin or anything to thin the blood, just have it at a different time in the day. That's about it. And just watch the INRs if you're getting INRs on these patients. Retinoids and other antibiotics. So just looking for competing mechanisms of action. So doxycycline is doing something that's antimicrobial, anti-inflammatory, and these medications do the same thing. So just make sure you run it through the MAR, talk to your pharmacist to make sure there's nothing you should be watching out for. So where are we right now with national guidance? So right now, as of October 2nd, there has been the ability for public comment to occur on what the CDC should do. So the public comment is still available. You can still chime in from the community or from your center and give an opinion on this. And it will close on November 16th, so next week. And right now, this is what they're saying. This is the proposal, and then they will take the comments and kind of finalize it and then publish it for everyone to see. And that includes this. And it's actually really nice and reassuring to see that it is basically a copy of what we're doing at Fenway at this point. So it is an A1 strength recommendation from the expert panel that this DoxyPEP should be considered for gay, bisexual, men who have sex with other men, and transgender women who have a history of 1 bacterial infection in the past 12 months. And that is taking 200 milligrams once orally within the first 72 hours of oral, vaginal, anal sex without a condom. Now, what is not recommended, but not because it's contraindicated, just because there's insufficient data, which I've stated, is for cisgender women, cisgender heterosexual men, just because we haven't looked at it, transgender men, so assigned female at birth, and then other queer non-binary folks. So this is just because there's not enough data. It's not to say that it can't work, it's just to say that we just don't have a published consensus on this. I think that's it. I think I'm going to turn this over now to Jen.
Thank you so much, Taimur. And before we continue, something that I forgot to mention for the folks attending, if you have questions, make sure to put them in the chat and we will discuss them at the end of the webinar. Thank you.
Thank you so much. I really appreciate that very thorough presentation. Can you all hear me? And can you see the slides?
You can see the full app.
And let's see what happens if we do this. Still no change. I'm not sure why that is, but I think you'll just get a little bit of extra information. So I'm Jen Hecht, and I am presenting from Building Healthy Online Communities. I'm a co-founder and director of BHOC, and I'm presenting on behalf of both myself and Emmett Patterson. And we're basically here to talk about how do we share this information out in the community. So I'm going to go ahead and get started just by sharing a little bit about who we are at BHOC. We are a consortium of public health organizations. You can see our partners here. And we work in partnership with dating apps. And our goal is really to improve sexual health outcomes of people who use dating apps. We do that in a number of different ways. These are some of our major initiatives. First and foremost, we were really working with dating apps on new features related to sexual health and well-being. We also have created many standalone resources and resources that are linked to out of the apps or promoted out of the apps for dating app users. And we also have created resources for public health and our public health providers. So one way that we work with dating apps is to share information through the dating apps, and that can be through features. You can see here on the left, we have an example of a feature that we worked on with Sniffies, where in addition to being able to see potential sexual partners, you can also click a toggle to see testing locations on a map. You can see here in the middle, we worked with Grindr on including information about DoxyPEP in the sexual health. They have kind of a sexual health FAQ section. And then we worked with Adam for Adam and other apps on ensuring that there is ways to indicate MPOX vaccination status. So those are some examples of how we've worked with dating apps. We've actively been working with dating apps on DoxyPEP info. So both Sniffies and Grindr have DoxyPEP information in their resource section that we helped write. And then we're also looking into and having some preliminary discussions with dating apps around what kind of profile options or information may make sense to add so that folks don't have to just, type it in themselves. We've worked with many apps around adding the ability to disclose or indicate if someone is on PrEP. So this may be something similar, and we're kind of in the early part of those conversations right now. And we want to talk a little bit about kind of how we manage information, and for us, it's really important to get that information out as quickly as possible. We really want to think about what information there is already available. I think Dr. Khan referenced this already, who is DoxyPEP recommended for, and where do we have insufficient information? We really want to be thoughtful about that. And then we also really want to be thoughtful about where do we see information gaps, especially, we also want to consider language. And so wherever possible, we really make an effort to have bilingual communication. And, just some considerations as we're putting information out, and I really want to lift up a lot of the work that Emmett has done around this. So the first thing is to acknowledge what we don't know, right? So oftentimes we're saying, here's what we do know about DoxyPEP, but also here's what we don't know, and here's who is not currently included, that we want to make sure we acknowledge that. We want to be thoughtful about the type of language we use in regards to gendered language and which bodies are being referenced or included. And we want to sort of lead with pleasure. So we can think about additional, celebrating an additional tool in the toolbox. That's always exciting. And trying to answer as many questions as we can without centering fears. We really want to be thoughtful about using terms like unsafe when we're talking about sex. And so we just are trying to be very thoughtful about our language and about how we might inadvertently perhaps moralize or pass judgment. So I think we're trying to be as thoughtful as we can around language. And then getting into the nitty-gritty, really explain, give details around, what's the process for getting it, especially with, newer tools. Sometimes it's often incumbent upon, people within the community who are advocating or educating their providers. So wherever possible, we try to either share that information, link out to additional information from partners that we know have created it. And then really just think about wherever we can provide community resources and support. On our Instagram, you can see an example of a post that we shared that Emmett put together around DoxyPEP that kind of describes some of this basic information, and again, ways in which it's sort of lifting up pleasure and also sharing some crucial information. So please go ahead and check that out. I know we're going to come to discussion and questions after Raul speaks, so I will hold off on that. And I will just encourage you to go ahead and contact us if you have any questions, to follow us on social media and check out some of the resources that we have put together. And then I am going to pass it over to Raul. There we go.
Hello.
Okay, Raul, thank you so much. Good to see you again.
Thank you. Okay. So everyone can see my screen. Okay, so hi everyone. So we know, like in recent years, social media has been changed how we interact, how we communicate, or how we collect information. So we know the role of social media in the health sector is growing so fast that now I think like we know that's ideal tool to do awareness campaigns, health alerts, or promoting health services, among others. Hi everyone, my name is Raul Marca. I'm part of the NMAC Gateway of Color Fellowship and CDC ambassador for the campaign Let's Stop HIV Together. So I use my social media to promote different sexual health tools, like so that helping me to kind of like give the possibility to connect with a lot of people. So one of the things I did is kind of like connect more than 30 people to health services through the nation, through the whole nation. So with that, I found out how the power of social media. So we know the use of social media involves our communities to be connected in the real time. So with that, we can see the barriers that they face. So with that, this can help in us to kind of see an effective strategies and best practice for knowledge and dissemination and community participation. Okay, sorry. Okay, so social media has transformed the numbers of people who share or consume health information. As an example, I've been at different campaigns that BHOC has carried out to social media, such as collaboration with health providers, different organizations and community members. So that shows us the potential of social media, how can increase the knowledge or awareness and acceptance for DoxyPEP among the key groups of young people who might be being risked. Here's an example. So as you see in the presentation, this is an example how people began interacting with the reel that I make on Instagram on my social media account. This is something that's the collaboration that I did with BHOC. So what I see in this specific reel is how it was very important to make this reel in Spanish, because people they didn't kind of like know what it was DoxyPEP. So you can see that like different comments, people there was kind of sharing, the people there was happy, and the people there was very happy to kind of like see the information. So as we know, people who speak languages other than English face barriers or accessing care. They face different barriers. So that can kind of like stop to access to care or different quality care. So that's why it was my focus to do this information in Spanish. So we know these people, they can identify like all the information. So everyone must be strange. Every has to be, I think like we need to do is kind of like to helping people to get information, how we do it, how we connect with them. If we do it in the right way, or we don't do it in the correct way. So we have the tools, we have everything, like BHOC, like NMAC, or like Let's Stop HIV Together campaign. They give you the tools. So the only thing that we need to do is just making sure that this information goes to the people that need it. Thank you.
Awesome. Thank you so much to all of the presenters. Thank you so much for sharing your expertise with us. Before we go to the okay, let me close this window. Before we go to the Q&A with the audience, one of the things that I wanted to mention is that, you know, this webinar or this conversation about DoxyPEP really comes from a place, a little bit of worry, you know, because one of the things that we have seen throughout COVID, MPOX, HIV is that there's like an expectation that there are going to be disparities for communities of color, right? And it's sad to say that there's going to be, you know, that we are going to observe these disparities. And one of the things that I know that you have mentioned, language justice, making information accessible, seeing the, for example, in BHOC's material, how the community can see themselves represented in the visuals that you put out. So I would like for you to expand on the implementation side. What can we learn, for example, from HIV of what has worked to reduce those disparities towards communities of color particularly? Anyone would like to start?
I can start. It's actually interesting you bring that up. So when it comes to disparities in marginalized groups receiving these novel new treatments, preventive measures, it is like multifactorial. Some of it has to do with just physical access to the space. The other one is preconceived notions and attitudes from providers. And then the last part is representation. So when it comes to representation, I think, at least from a science research realm, there has been more of a spotlight placed on research to include, if you're going to make generalizable conclusions about anything, that everyone should be represented, right? And especially people that require or are at more of a need. So I think there is a spotlight on that in the research realm. Access is an ongoing conversation, right? So when I mentioned that the CDC released that map of congenital syphilis cases in mothers that have, or people that are about to have kids with congenital syphilis, the map actually specifically said at the bottom, the data showed that it had to do with access and the ability to get prenatal care. Like that was a big thing. So once you tap into that, then the next barrier is attitudes from providers in the healthcare setting. And I think that's kind of where the hiccup is right now. It is, providers are already, the healthcare system is already spread pretty thin across the board when it comes to giving care to anyone, but then to add on marginalized groups that have higher needs, which is not their fault, right? That is like a systemic racism, history of racism, institutional racism that has consequences generations down the line. That when patients come in, they have a lot of needs that need to be addressed, and they need to be addressed, right? And it's how do you get providers to be comfortable with adding on another layer of care when there's already socioeconomic issues, food insecurities, basic vaccinations, COVID vaccinations, PrEP, and then DoxyPEP, et cetera, fill in the gaps, right? And so that is added burden on the healthcare system, as well as requiring providers to learn about a new therapy or preventive measure on top of the things that they're already getting graded on, right? They're getting checked on A1Cs, they're getting checked on hypertension. So it is a complex system. And I think once providers get comfortable with doing this in the populations they already can, it makes it easier to do with other groups. But I don't think it's a simple one thing issue. I think it has to do with multiple things.
I can add on to that a little bit. I mean, I think that was a very thorough answer, and I think very clearly it is not one thing. There's so many different factors, and that's why we've seen this happen over and over and over, right? I feel like just, you know, very recently we went through this with MPOX vaccinations and thinking about, you know, how do we have to learn lessons from these prior experiences of you can't just have first come first serve, right? Because that then, you know, folks who have, you know, easier access are gonna get access first, and then that's not equitable, right? So I think having really intentional strategies about addressing that, you know, information gaps and opportunities. And I think these kinds of partnerships where there's a specific effort to say, how do we ensure that information is flowing as widely as possible, and engaging folks from all groups in order to be able to ensure that information flows as widely as possible, and really being thoughtful when you're creating an information, putting information out, that there have to be many different channels used, and really thoughtfulness about who's a part of sharing those messages. So I know that's certainly not the full answer, but I think it's one more layer to be thinking about as we recognize, we're exactly in the same situation again with DoxyPEP as we were with PrEP, as we were with Mpox vaccinations, to really be thinking about, we know this is going to happen, unfortunately, and so what can we do to mitigate it, right from the very beginning.
And then I just want to add that, thank you, is how all these platforms and how we try to kind of empower people, because this is kind of the key, like empower our community so our own community, they can bring that to the providers, because that happened a lot, like with all my comments on the social media. People say like, oh, I went to the provider and then I explained to them about DoxyPEP, and they didn't know anything. So that's why I think that's kind of like the main goal for us, like to continue empower our community.
I was literally about to say something similar to Raul, which is like, we know that I mentioned like healthcare systems are stretched thin. So when a patient shows up and asks for something, and kind of put the doctor to shame, not that that is the expectation of the patient, that is not, but to at least put a spotlight on it to say, hey, my friends are doing this, I want to do it too. It may encourage or force their hand to be more comfortable with it. And from like a system standpoint, like remove any excuse from providers, create smart phrases, make it easy, provide lectures, send recordings of this webinar to providers to have them see it. I want to push back ever so slightly on Jen's statement that we're in the same place as we were with HIV. The benefit is we have time and we have systems in place like NMAC and other organizations that advocate for these things. And if we're looking at these as endemics, where it's not just one thing happening in a vacuum, we can appreciate that they can piggyback on each other. Fauci and our entire US population, I don't want to say abused, but repurposed our HIV trials networks to do COVID research. In the same space, we have these networks and abilities now to be able to move these a little bit faster than in the past. So yes, I agree with Jen to say, we're seeing the same weak spots, we definitely are, but there are other things in place that we can kind of piggyback off of. And I think using this webinar series and NMAC to kind of get this information out is one example of that.
Yeah, and from what you were all saying, what I get is that, there are many systemic and societal barriers towards, accessing treatment and prevention, whether it is for DoxyPEP or HIV. And also, if the implementation from the start just does the minimum necessary at a systemic level, it's going to serve only those who already have access. So as Jen was saying, there's a lot to learn from HIV and from many of the other fronts that we have been dealing with. So I will pass it over to Taylor, who's the communications manager at NMAC. She's behind the scenes and she will read your questions out loud. Can you hear us, Taylor? There you go. You are unmuted, but at least I can't hear you. Taylor, can you hear us? I see that you are unmuted, but I cannot hear you.
While we're waiting for Taylor, can I do a super quick reminder? Taimur brought this up in your slides that public comment is open. So I just want to remind folks that public comment is open right now. We have some information on BHOC's Instagram account if you want to check that out about what that process looks like. But again, we just want to make sure that folks know this is an opportunity to give some feedback. Particularly, I think it's important to note all the populations and groups for which there is insufficient data, that I think it's just kind of a reminder that there's an opportunity to sort of jump in and share the importance of getting sufficient data for those groups as well.
And the deadline is November 16 for those who are interested in providing any public comments. And sorry, folks, we are trying to get the questions from behind the scenes, so apologize for that. Okay, so far there are no questions from the audience. We have around 9 minutes, but thank you for touching base on that, Jen, because I think this is one of those unique opportunities where people who are disproportionately affected have an actual voice to provide feedback and to kind of shape this kind of efforts and to really shape the implementation. And I really hope that many people from who NMAC collaborates with really have an opportunity to submit that.
Can I make a point just for organizations as they gather this information, which is, at no point did we make the decisions for the community. We received information from the scientific experts, and then we actually talked to providers. We asked them, what have you heard from patients about it? What have you heard? What are your concerns? And then equally, we did a check-in a few weeks after starting this in small amounts. We had like a town hall open to the community with community organizers to come in, and we did like an anonymous survey about what the community concerns were. And we also had an open forum where people could discuss in the community about what they thought was appropriate, what wasn't, what required more information. So I know when we start creating policies, it's easy to get into the weeds and fixate on, oh, the data is so good. And I can make assumptions about what I think people will think about, but then I'm always continuously surprised by what people are actually feeling and concerned about. So I would encourage everyone to kind of do the same with your own communities and organizations, both on a provider stand, like a healthcare system standpoint, as well as from a community standpoint.
Yeah, absolutely. And then one of the things that really you've all made me think is about how there are so many similarities to all levels, right? Not only language, but also provider knowledge, provider bias, but also the community. For example, when PrEP came out at the beginning, there were doubts from the community. Also, we saw this the same with COVID. So I think there's a lot of things that we can learn from things that we have done in the past. And one of the things that I think are key at this point in history, right, is that to be able to provide the community with not only the information, but also with the space where they can take decisions or that they can advocate for their communities. And one of the things that I think is crucial is how us from our standpoint and from our organizations are able to develop leadership in communities and to be able to provide our own platforms to the communities so that they can voice their own concerns, their own opinions, and again shape the implementation of this program, which again there's an open comment available until November 16. Again, that's super important. But yeah, I think that on my experience, that's one of the things that really has worked to shift things, right? To be able to provide that those tools to the community so that they can talk for themselves. And I think Raul is a great example of that in terms of not only the Gaming of Color Fellowship, but also the work that you do with the CDC in being able to represent and talk directly to the community, to the Latino community as a trusted messenger.
Yeah, it is. And then as you mentioned, like social media or like just be yourself, like is very empowered and people very connected with you, like very, very, very connected. So I think everyone like uh, organizations, they can kind of like do the same, like just put like kind of like real people like who will be talking. Like when you're using social media to do your video, you just put in real people, just like a real person who gives the services. Put them then, and then give an information, because this is how people are gonna be connected. If not, your post that will be there, and nobody's gonna see it. So find people from your community, so that can help to kind of like to spread the information that you need.
Patients are in the community is already using this. They've been sharing it in Europe way before they started sharing it here, and so patients are sharing it with their friends, with their sexual partners, and so it's a matter of kind of helping to engage, build trust, and also kind of fight alongside our patients with these issues that are kind of coming up in the community.
I also want to share another resource that we have on the BHOC website. So on the BHOC website, in the sexual health information section, we have a section on DoxyPEP. There's information there that may be of use to folks. There's also links out to sort of processes and protocols that were created by several different health departments, San Francisco, California, and Seattle. So if that is a barrier for folks, is creating their own protocols, this is a reference that folks may want to use, or feel free to grab it. And we thank those folks for sharing that information to make it more widely accessible.
And that's something that I really enjoy, because sometimes the information around DoxyPEP or HIV in general PrEP can be sometimes overwhelming, especially in some places where the information is super, super clinical. And I think that's one of the barriers that we have seen, right? When we only refer to, when we only address, or when we only provide this information from a super clinical perspective, we put a barrier between community members and that need this information. So I think you all have done a great work to to summarize the findings and to be able to provide the information in a way that is really, really accessible for folks. I know that we have a couple more minutes, so you still have the opportunity to ask questions on the chat before we close out. But I wanted to thank you for providing the information on the resources that you have. Again, I'm going to ask Taylor if you can post it on the chat, the BHOC materials on DoxyPEP, and also the links again for the Let's Stop HIV Together campaign, where you can find lots of things regarding HIV treatment and prevention, and most importantly, where you can get services around you. And if there are no more questions, I am going to be closing this webinar. I really thank you all for your time, your expertise, all the information that you gathered, that you put out. So thank you all so much, and we will see you soon.
Thank you.
Yeah.
Ciao.
Bye bye.